So nothing says Valentine's Day and post Super Bowl hangovers like surgical site infections, but that's where we're going anyways. So we're gonna go through some epidemiology, pathogenesis, classification, briefly, prevention, and then some notes about treatment. So on incidence, it's the third most common complication after spine surgery, ranging between 0.2 and 16%, depending on the study and the patient population. Causes hospital readmissions outcomes, debatably worse, but generally worse, and then significant additional cost ranging from $1 to $10 billion per year, as well as approximately 8,000 deaths per year. This is a table looking at data from the National Healthcare Safety Network. It's a big data dump from 1,500 hospitals, and they risk-adjusted surgeries based on ASA score, wound class, and whether or not that surgery went over the 75th percentile in terms of duration. And then you get 1 point for each. And you can see the relatively linear worsening in odds of infection with each successive point on their scale. And see the 75th percentile for duration of surgery there, spinal fusion of 4 hours. So pretty significant in terms of the effect on infection. And then from that same paper, looking at odds ratios of various patient demographic factors and their contribution to risk of infection. See transfusion and CSF leak pretty high up there, over 3. Then a study looking at nutrition, specifically this prognostic nutritional index had 1,100 patients, and 43 of them ended up with a surgical site infection. And I'd never seen this scale before, but it's relatively simple as far as prognostic scores goes, just albumin and lymphocyte count. And they found that it was statistically correlated with risk of infection. They also found length of surgery, BMI, and male sex revision status, which were all pretty common across other papers I looked at. But this is a paper out of San Diego. You may have heard of this place. Multi-center retrospective database review. They looked at about 380 patients with growing rods, and 11% of them developed surgical site infection. Mean time to initial infection was 2.8 years. And then risks they found were stainless steel over titanium, which was significant. Stainless steel carrying odds ratio 5.7, and then non-ambulatory status and the number of revisions prior to development of infection was 3 times. Another paper, this one out of Leatherman, looking at patients with posterior cemented fusion and less than 3-month post-op infections. And then they used a propensity matched control group, which we've all heard about previously, but they looked at ODI, SF36, and other outcome measures, and they found that the infection group had worse back pain scores and a greater proportion of patients that met the minimally clinically significant difference in terms of their ODI change. In contrast, though, a different study looked at 13 patients. They were focusing on satisfaction. They also looked at some outcome scores. They had a matched cohort group, 3-to-1, and then they looked at post-op infections. They were all treated similarly, retained instrumentation, and they found no difference in terms of pain or function, quality of life, but they did find a significant difference in satisfaction, with 53% of the infected saying they were not satisfied, compared with 15% of the patients that didn't have an infection. So pretty significant change there. And then one set of outcomes looking at MIS versus open. This was 1,400 cases, 900 open, or 900 MIS, 400 open. And their overall infection rate was 1.5, which was significantly different, 3 and 0.5, and then carried through with decompression versus decompression infusion. It looks like they didn't have the numbers for decompression infusion, but it was trending towards at least some difference. In terms of pathogenesis, typically surgical site infections are going to occur through direct inoculation during the surgical procedure, and the most common source is endogenous skin flora, which is generally coag negative staph, P. acnes, and various species of Corynebacterium. The most frequent cause of infections is Staph aureus, it's about half, and then 35% of those infections are primary cases, and 48% in revision cases are methicillin-resistant staph, and that number keeps going up. This is a paper looking at all of their infections over 240 cases, and you can see there kind of fits the bill in terms of the typical organisms. The same paper, staph epi also accounts for 31%, and then gram negatives are the majority of the rest. That same paper looking at those 240 infection cases saw the further you go down, the more infections they had, and then these gram negative infections tended to be more common the further down you are as you get closer to the perianal region. Briefly on classification, I couldn't really find much in terms of infection classification specific to spine, but this was one paper looking at 32 patients from 1985, but it was at least an attempt to classify things, so I thought it was worth including. They categorized patients by severity and type of infection. So group 1, they were single organism, group 2, multi-organism, and then group 3, multi-organism with muscle death. And then they also classified patients by their host response or their ability to fight the infection. Class A's were normal. Class B's were some type of systemic disease or smokers. And then Class C were significantly immunocompromised or patients that were polytraumatized with injury severity scores greater than 18. And then using that, they kind of suggested treatment based on the group the patient fell into, with group 1s being more or less a single irrigation debridement, simple closure. Group 2, they were finding were requiring multiple irrigation debridements, and then either using closed inflow outflow suction or constant inflow. And then group 3, they basically said it was tough, which doesn't help too much, but just gives you an idea of what you're in for if you have a patient in that level of distress. In terms of prevention, there's been a whole number of papers looking at various different ways to try and prevent infection. In terms of diabetes or glycemic control, one of the things that Mann et al. Looked at was the odds ratio of patients that have diabetes, and it was 2.04 in their study. Another study by Kody et al. Looked at less than 7 or greater than 7 in terms of the A1C levels, and under 7, they had 0 in their infection group, and 35% in the over 7. In smoking, the MEG study again had an increased risk of 1.17 after spine surgery, but they did find in a different study by Thompson that surgical complications were decreased in patients who quit smoking. So it didn't carry a like long-term problem, and they found that if it was 4 weeks prior to surgery or sooner, it had the effect, but it didn't matter if it was less than 4 weeks prior to surgery. In terms of obesity, this is something that I think we all talk about, but I haven't seen documented other than this meta study looking at skin to lamina distance, or the thickness of the subcutaneous tissue, as a further marker for possible infection rate. They found that it was associated with increased rates in their study. And then that same MEG study also looked at BMI, and they found odds ratio of 2.1 with BMI greater than 30. In terms of staph carriers and what we should do about that, there's a randomized controlled trial looking at mupirocin and chlorhexidine versus placebo, and they found the placebo group had a 2 times greater rate of surgical site infection And then a study by Kim et al. Had 7,000 patients, and they found a higher rate of surgical site infection in MRSA carriers compared to people that weren't carriers. In terms of skin prep, there's a number of articles looking at the various types of skin prep and whether one's better than the other. Paper by Savage et al. Looked at 100 cases, ChlorPrep versus DuraPrep, and found no difference. However, there are a number of different randomized trials that cite one is better than the other, or that there's no difference. So jury's still out on that one. In terms of surgical gloves, there's a Cochrane review by Tanner looking at double gloving, which they found does significantly decrease glove perforations, and that if you wear different color undergloves or indicator gloves, that they had a significantly earlier detection of perforation. And then a study by Raymond looked at 180 patients undergoing spinal fusion. They found a significant reduction in surgical site infection if the surgeons changed their outer gloves prior to handling instrumentation, rather than just wearing the same double glove pair the whole time. Looking at betadine as a possible infection prevention measure, this study by Cheng et al. Noted that the maximum effectiveness for betadine is between 0.5 and 4% and doesn't have any cytotoxic effect below 5. So they used a betadine solution of 3.5% in a randomized single-blinded trial looking at 400 cervical patients, and they found a decreased deep infection rate and decreased overall infection rate with the betadine wash solution. Antibiotic sutures, another possible infection prevention technique. A study by Uno et al. Looked at a retrospective cohort using this triclosan coated suture compared to standard suture for their closure, and they found that it was effective in terms of surgical site prevention, but also quite costly. And so they did a cost analysis, and they found that if you can prevent one spine infection in 200 cases, then it's worth the extra money for the antibiotic sutures. And then bank powder, this could be a whole separate talk. This is just a small representation of all the studies that I came across for bank powder, and the retrospective reviews and Cochrane reviews. And I think the jury is still out in terms of how much and when, and if it's truly effective, and are we selecting for gram-negative species and rat models looking at dosing requirements. But I think if you believe in bank powder, you can find plenty of studies that will go with you on that one. And then if you don't want to use it, I think there's enough studies that say there's no difference, or you're selecting for bad bugs, that I think that would be a reasonable conclusion too. But it's kind of all over the place, and definitely a question still being asked. Looking at post-op, so some dressing studies that were done. One study by Epstein looked at silver impregnated dressings, and in their study they found relatively small sample, but they had 14 infections in their regular group and 106 patients with no infections in their silver dressing group. And then as far as wound vacuums, I couldn't find anyone specific for spine, but these are some other ones looking at randomized controlled trials in total hip arthroplasty with a 3% reduction in surgical site incidence, and then another one looking at a variety of procedures that cited a reduction in not only infection but also seroma formation. And then Standard et al. Randomized controlled trial looking at lower extremity fractures, but they found a surgical site reduction of almost 10%. So there's some promising data there. And then this is a study looking at systematic review of 41 studies, 9 randomized and 32 cohort, and they found that antibiotics outside of the standard preoperative and intraoperative dosing did not reduce their rate of infection. Also, that prolonged use of antibiotics for more than 48 hours didn't have any effect either. and that the placement of wound drainage systems like normal drain smoothly didn't alter their overall infection rate, and neither did the length of antibiotics as it related to the length of time the drain was in this study in terms of deep or superficial infections. They also looked at some enhanced recovery pathways and institutions that had instituted infection-specific protocols, and in this in this systematic review, they didn't find that affected the overall rate of infection either. So to treatment, this is a study, sick bourbon, looking at 225 consecutive surgical site infections. They were all treated with IND and antibiotic therapy, and they defined success as resolution within 90 days. They were able to retain implants in 76%, but they did have 22% treatment failure and 5 deaths overall in their study. They found that the worst rate of success was seen in patients with later infections, patients that refused to the pelvis, P. acnes or polymicrobial, and then long instrumented cases greater than 5 levels. They also found that positive prognostic factors were superficial infections, MSSA, and then less than 3 levels operated. And doing multivariate regression in that same group, they found that late infection was the most significant factor in treatment failure, and that superficial or MSSA were the best predictors of an earlier resolution of the infection. Another study Dr. Barney was involved in here, retrospective review of 500 posterior instrument infusions with 28 infections, and they proposed a standardized treatment of IND and closed suction irrigation system. In this group, they had 21 acute and 7 late infections, and they followed them for almost 2 years. 75% of them were able to be treated with just one course of this closed suction irrigation system, and then the other quarter required a second treatment. One of the drawbacks is the length of hospitalization for those procedures, 15 days, and then almost 29 for reinfections. But no patient required implant removal in the acute infection group, and the reinfection group tended to have higher blood loss, more levels fused, and longer hospitalization. Another technique for, I guess this is technically a prevention technique, but 2,600 patients who had multi-segmental lumbar surgery, they randomized them to hydrogen peroxide versus control. And in the hydrogen peroxide group, they would soak the incision with 50 milliliters of 3% hydrogen peroxide for 30 seconds. And then both groups would get a liter of saline. And they found that drain outputs were lower and surgical site infections were lower in the hydrogen peroxide group. And there was no significant difference in perioperative complications, DVT, PE, MI. And then in attempting to put together a scoring system, this group, a study by DePaul et al. Looked at 128 patients that they had who required an IND for surgical site infection, and they basically shotgunned more than 30 variables to look at predictors for who would require more than one irrigation debridement. And then they took their sample size, or they took their infection sample and used it to bootstrap a predictive model, assigning point values to various factors that they found were significant. And then they took a second series of 34 patients and used that as an external validation to their prediction model. And you can see there the model they came up with, looking at 6 different parameters and various kind of weights to each of those parameters based on their prediction model, with things like non-autograft, bone graft, and instrumentation ranking pretty highly in their scoring system. And then based on that scoring system, they developed a at least moderately predictive algorithm of who's going to require multiple irrigation debridements or is likely going to require a single irrigation debridement. So on their scale, you were 7 to 14, you're most likely to only require one IND, and over 21, there's a high risk you end up with 2. And then that 15 to 20 is kind of a indeterminate. And then just a kind of summation algorithm of how we should go about treating these surgical site infections. This is a paper by Vaccaro proposing a diagnostic algorithm and then also a treatment algorithm based on literature reviews. And some points that they stressed are diagnosis of the bacterial agent is key, and then appropriately tailored antibiotic therapy is kind of gold standard, no matter how you intend to manage the infection. Hard indications for surgical treatment, where neurologic deficits, progressive sepsis, instability or deformity, presence of an epidural abscess, or failure of conservative treatment. And then they propose a treatment algorithm kind of following their hard indications for surgical intervention, and also kind of giving you a roadmap of what to do if it's not working. And you can see kind of if you get in the middle there, negative evolution, or things aren't going well, then start at the top again. And things they found were prognostic for poor outcome were older patients, and specifically people that were paralyzed or had bowel bladder function loss at presentation. So not the most detailed in terms of their treatment algorithm, but it gives you a good kind of framework to think about infection. I think something that if you have a patient that's coming in with an infection would be a useful thing to kind of think through if you're going to be the one taking care of the patient. That's it.
Hey, thanks for that. And I'm not a paid speaker for the VAC Veriflow system, but again, I just want to reiterate how amazing and transformative it's been in taking care of patients with infections, because instead of having to go back to the OR every 3 days and wash things out, you just pop this irrigating sponge in, and at whatever hourly cycle you want this thing to instill antibiotics or Dakins into your wound, it does it and then sucks it back out, as well as the benefit of the VAC where it does sort of that wound edge debridement. I've had, several patients show up with epidural abscesses and, put this thing in, and it really kind of cleaned it out. So you do one IND, you let it sit, and the wound team change it a handful of times when their numbers start to come down in terms of ESR and CRP, and the tissues look good at the VAC changes, then you can just schedule for, a definitive closure. So really nice device. And I'm not a paid speaker.
Yeah. I use.
Yes, you are. Yes, you are, Don. Yeah, you are. I'm kidding.
Veriflow system.
And I'm not a paid speaker 8 times. I swear I'm not a paid speaker. Yeah.
I use that Veriflow system a fair amount in residency, actually, for like bad open fractures. And the only thing I'll say against it is the concentrations that you mix into the bag that you put in are like incredibly high compared to what we normally mix into a similar looking bag. And so the nurses on the floor need to be aware that that's only for the Veriflow bag and not to be infused into the patients, because that's come up.
That's bad.
Yeah, one thing they do, you can put actually like one of those 250 cc like plastic containers, and it comes with sort of like an infusion cap, so it links to the system. So, it kind of helps to prevent kind of one of those accidental, IV infusions.
Yeah.
There's also some decent literature on using a ChloroPrep stick at the end of your case, just over after you're done closing everything. and then applying a new prep to the area that will be under the dressing, and then allowing it the 2 to 3 minutes to dry. So there's, I can send you the studies on that as well, but it's pretty substantial drop in infection rate, even with just a simple at the very end, just making sure everything's clean, because a lot of the flora that ends up causing the problem is actually on the skin, but the prep actually wears out after time. So patients at higher risk and longer surgeries for sure could be from just the bacterial overgrowth on the skin surface again. So if you just eliminate that one more time prior to applying the dressing, that works out.
That's awesome. I've been doing that for a bunch of years, and I started a little pilot thing where I did like 10 patients, where when I took their IABAN off at 10 days or 2 weeks in the office, I swabbed outside of the dressing. And of course it comes back with skin flora. And then I swabbed underneath the dressing right at the wound edge, and they were negative. Nothing was growing. So I think it really kind of reinforces using like a prep stick at the end and then putting on an IABAN and leaving it.
Silence.
I know. I guess I just dropped the mic. Everybody has nothing to say. We're done, huh?
Yeah, I can say something.
Dr. A, thank you, please.
Well, I think that some of these studies also need to mention the long-term recurrence of infection, especially for those who you leave the implants in the subsequent surgeries and so on. That hasn't really brought a lot in the literature. But anyway, so Kody mentioned that irrigation, and I think one of the advantages of suction irrigation, which I think I agree that it requires a lot of detail, attention, and time consuming. But once you close it right from the beginning, and you don't have to go back again in 75% of cases, and that really takes care of just one surgery, and but it requires a lot of detail of making sure that the suction irrigation is going, and cleaning, and where you put the drains and all of the details, but has worked over 25 years or so, I think. But I'm sure now there are better technologies that save some time, I guess, on the part of surgeon and the care team. So
I don't know. Like, I think you're right, Dr. Akbarani. I think especially in some of these, the ones where you're worried about having to go back in, having something like that is really important in some ways. I agree that the detail that needs to happen on the floor is pretty intense, and nurses aren't used to it. And that's always what I've found to be the biggest struggle in implementing it, is like the nursing staff. But I will say, if you only have to close the incision once, then, those of us that have been on wounds that are, 4 or 5 INDs later, the tissue's terrible, and probably the best thing is to bleed it once, get a very good bleeding edge, and then put it back together. I agree. I think it's the ideal way is to do what you're talking about. So.
Yeah, reading that paper
takes effort on the part of the surgeon, and that's we're so used to just doing something and then being able to walk away, but like this really requires the flow.
Exactly.
Yeah.
The resident or fellow was sort of responsible. The first night was really crucial.
Yeah, I can only imagine the number of nursing pages or calls when you try and inflow 100 cc's an hour with multiple drains.
Yeah, and you're only getting 70 back. Then they're like, "Well, where'd the 30 go?" And you do that 3 hours in a row. You're like, "Wait a second, we're we're going the wrong direction.
Yeah. So the specific details of orders, if it happens in 2 hours in a row, call us.
Yeah.
We go there.
Yeah.
We're not just ordered by phone.
Right.
Yeah, that would keep you up all night as a junior resident because you would be going to check these patients out. And Dr. A, we used your system on somebody with an infected subdural at one point too. So we
Really?
could set this thing up in the OR. And then now imagine now you're putting in, like 50 cc's onto the brain. And let me tell you how the nurses freaked out about that, and appropriately so.
Exactly. Wow.
Well, good stuff, guys.
Thank you, Kody.
Yeah.